So, Assalamu alaikum and very good morning, ladies and gentlemen. Those who are online can confirm, are we audible? Dr. Adam, can you hear us?
Yeah, I can hear you well.
All right, thank you very much. So, very good morning from Lahore. We welcome all of you in this workshop on radiation physics. So, today's session is about 3 hours. So, at the beginning, we will just run a pre-recorded talk from Dr. Adam Wu, who is the lead Sabre physicist at Peter MacCallum Hospital, Sydney, Australia. So, we'll straight away start with the presentation. And then once the presentation is finished, so we will have a question answer session since Dr. Adam is online with us. And then after that, our colleague, Ms. Manas Kamar, she is the head of medical physics and she's just sitting beside me. So she'll just go through some of the plans on Sabre and SRS and SPRT. And we would like to have Dr. Adam online at that time so that if we have few questions and recommendations, so we'll just discuss in that session. So let's start with the pre-recorded presentation.
Hi everyone, my name is Adam Yeo. I'm proton lead and Sabre lead medical physicist working in Peter MacCallum Cancer Center. Today I'm going to cover challenges and some tips on stereotactic radiation therapy, quality and safety that cover both aspects of SRS and Sabre in general. It has to be generic to cover these broad aspects in a given and limited time of 45 minutes. Some disclaimer here, myself and Peter McTeam have research agreement with various vendors here. And I'll show some commercial slides and videos for illustration purpose from these vendors. And some slides courtesy from our team as well. There are three objectives to be on the same page. We'll define what is the quality assurance, how we do it in the context of SRS and Sabre. And we'll cover the common aspects between the two in terms of planning and QA. Also cover some specific aspects, the differences between the two as well. To start with some key references, so personally I see it quite useful. This is the Radio Surgery Society, AAPM Joint Practice Guidelines, as well as the supplementary material for the SRS and Sabre published in PRO. Also, there are the series of AAPM task group reports start from TG101 followed by TG142. Sorry, the other way around. And also more relatively recent one is the implementation guide for TG142, which is specifically assigned to task group 198. To start with the keywords and SRS first, typically SRS is a single fraction, but also it goes up to 3 fractions, even up to 5 fractions for the cavity and a bigger lesion size. But nevertheless, it's a small size and very rigid, and so we match based on the bony where we can see because the lesion is embedded inside the brain tissue, which is low contrast area where we cannot see. Typically, the isotropic dose follow-up is required unless it's abutting critical organs such as the brainstem. And then most importantly, the healthy brain itself is abutting the lesion. Brain, it is a very critical organ itself. And then tumor control probability and normal tissue control probability are very susceptible to a tiny little error. And then it's unique, but it's very well-known radio biology radio sensitivity. Whereas Sabre, when you say Sabre, it's anything outside the brain and head extracranial area, and depending on site, it various critical structures therefore have different radio sensitivity in present. It's less rigid and it's more heterogeneous compared to SRS in terms of the anatomy materials as well as dose distributions, and harder to fix, harder to immobilize, because not only the organs and target moves, also shape changes. Therefore, it requires often rigorous motion management, and it demands often non-isotropic dose follow-off. And it's a lot of GIG areas. It requires the rigorous image registration process similar to SRS. So intracranial and head of brain, it demands typically the accuracy a couple of millimeters, and the extracranial area, the multi-sites, most of its accuracy ranges from 2 to 5 millimeter, including the sites such as the thorax, and then GI structures as well as GU and spine and bony mats. And both an SRS saber is associated with the two characteristics in high dose per fraction in hyperfractioned area and also high dose gradient. Therefore, technically more challenging than conventional radiotherapy in many different aspects we'll cover, and therefore more rigorous QA program is required. So in SRS and SABR, the clinical experience does matter because in relation to conventional radiotherapy you're starting from, there are a lot of different aspects. The most notorious one is the random error in conventional radiotherapy. Now it becomes all systematic error. A single fraction, not only single fraction, but also three fraction. We better to consider individual fraction of 3 to 5 fraction treatment courses as individual systematic errors. And there's therefore interfraction motion, we regard it as intrafraction motion only in terms of immobilization and the IGRT and the tumor monitoring. And conventional RT we treat with uniform dose, whereas SRS and SABR, the stereotactic approach, is originated from heterogeneous dose distribution that is extent varying with the technology and treatment modalities. Therefore, what I want to say here in this slide is that continuous review is very critical because we admit that there's room to improve our quality assurance, quality control process. So in here, I want to pause about 30 seconds for you to think about what kind of experience you have different stereotactic areas, intracranial or extracranial across different body sites such as lung and bony mats and spine, kidney, and in pancreas and liver and abdominal nodes, and what kind of technology and different treatment modalities is available in your clinic. Also, what sort of motion management program is available in your center. One may say, we do a lot of particular site at SABR or SRS. One might say, we don't do much of the kidney or liver SABR, for example. For the definition first, the stereotaxy that's originated from the minimally invasive form of surgical intervention. It doesn't not only include the radiosurgery, but also all sorts of the other the surgical intervention procedures, such as simulation, ablation, biopsy, etc., which makes the use of 3D coordinate system, that's the keyword here, to locate small targets inside the body and to perform on them any actions, any surgical interventions there. An Astro white paper, it says that the adjective is stereotactic that describes, again, radiotherapy procedure, which is a target here, it's a small target, it's located relative to known 3D volumetry reference system. So we still use this physical frame in the gamma knife, for example, and this is a physical frame is referred to the known, very well-known 3D coordinate system to locate a small target inside the body. And we use this head frame as an example for our gamma knife patients, but this head frame is now frameless. the head frame is localized, the known coordinate system is localized to the LINAC. That's why the radiation beam, the delivery is referred to the known 3D coordinate system of the frame. But now more people in the frame system becomes more popular. The physical frame, and now it's replaced by the known frame of the 3D image as its own reference frame. In Peter Mac's SRS past workload, because the clinical experience matters, we stopped here since our iPlan from the brain lab system is now an obsolete system. We treated about the 250 each year. The vast majority of the brain mets, we also treat meningioma and also the ocular melanoma and other clinical indications. Since then, we've installed and clinically released the gamma knife, total treatment at 200 patients, etc. for the first year, and since then we treat 200 plus patients. And then at the same time, we sort of moved on with from the iPlan, from the brain lab, and it's replaced by its next version, the Elements. Includes, it allows the VMAT instead of the dynamic conformal arc from iPlan. Also, we have our Eclipse system coupled with the Velocity, our image processing software from Varian, and on top of the gamma knife. And then we have a multi-treatment planning solutions as well as delivery systems. Have two different kinds of the MLC, the high definition MLC and the normal Millennium MLCs in TrueBeam Variant platform. For the Saber, we had the 10 years experience review a couple of years ago. This published advanced radiotherapy, radiation therapy. And that includes entire cohorts, the tumor streams. And when you look at here, so all those, the breakdown in terms of the fraction numbers, they're really a big highlight from our Saber practice is that very heavily geared towards one single fraction since 2019. And even the second fraction, the two fraction regime is the second most popular one. Typically 28 to 30 gray for lung, and then 20 gray single fraction for bone and abdominal nerves and spine, and then 24 gray in two fractions, getting more popular for the spine, and as well as the pediatric patients. So what we want to say is now, obviously that's the trend, especially since COVID, the single fraction or the two fraction Saber and the SRS, it is the future for the obvious patient throughput, as long as the safety concern is erased. So when you concern that the single fraction really safe, yes, it's coupled with the expertise built up from the 3 to 5 fraction Saber clinical experience, and then we can confirm that a single fraction Saber can be safely treated within 40 minutes of treatment time slot using TrueBeam beam, and then the treatment time really directly correlates to how many cone beams we take since the initial setup. The success of the Saber and SRS program is really we try to catch both rabbits, the precision as well as the accuracy here. The criteria have to be met, including the IGRT motion management, which is the key for the success of a stereotactic program, which can actually enable to minimize the volume of the targets, as well as overlap the organs at risk around, and so to preserve the critical organs function, and therefore we can maximize the sparing of the organs at risk, and that allows actually dose escalation further as an isotoxic approach. So to think about what is actually the QA process is involved. Every single product, when you buy your clothes from the shopping center, that product has been QA'd. So all those planned and systematic action necessary to provide confidence to a product or service will satisfy given requirements for quality. So the good QA systems in radiotherapy typically it improve the work practices and also would have prevented most of the major the incidences and the near misses. So how safe is safe? The fact is we have our limited resources, but the QA is essential in radiotherapy. Everyone acknowledges that, and the physics is essential part of it. That we spend time and resources, we invest, and we may delay things if it's necessary. So, but everyone wants to pick what is valuable and try to minimize the redundant checks. So no one wants to go beyond the tipping point of the diminution of the returns. So you have to think about the probability, the likelihood, and its severity when you perform the QA, the tasks with a limited resource. That's why, apart from all the technical factors, the QA is all about the multidisciplinary teams, work culture. So the work culture needs to be safe. Everyone should be free to ask questions and to check what is necessary. The three general areas, machine QA, of course, to be covered first, and treatment planning area, also patient treatment to end with. So stereotactic specific QA, we can divide into two different groups of errors. One is geometric error, which is related to the linear mechanical imaging, ISO related, and the other one is dosimetric error, which is related to treatment planning system, also the detector related to confirm the high precision and high accuracy. So this is the snapshot from the TG142. The purpose of showing this is not about going through every single test and its criteria, but when you look at stereotactic column, there's a much tighter tolerance compared to conventional radiotherapy because that acknowledges the more rigorous QA program is required. So the geometric error, there's a mechanical which covers the gantry and all the three rotation axes, such as gantry, collimator, and couch, and the jaw calibration, and the discrepancy between the imaging ISO to the treatment beam ISO centers, and virtually all of our stereotactic program, the beam is confined, shaped by the MLC. Its discrepancy against those rate and the gantry speed for our VMAT delivery is very crucial. So what I want to really highlight here is when you look at the history of our QA programs, it started from TG40 nearly 30 years ago, checking really the absolute specifications. But now we moved on to TG142 that highlights the check against the relative specs. But since the TG100, which is published in 2016, that changed the paradigm, deciding our what to do and how to do on the check frequency based on the risk assessment. Consider impact on the objective and the likelihood. So where we are at, to be honest, is sort of in between, still in transition period from relative specification check to the risk-based check. So I want to really change your focus from this relative, the check against relative specification to our risk-based assessment. In order to do that, the reason is the stereotactic, the technique is more risky inherently by its nature compared to conventional RT. So how does the higher risk translate to patient-specific the corollary assurance and quality control procedures. The fact is, our resources are limited. At the same time, the literature and recommendations quite generic. It's because it's not the fault, because depending on what sort of treatment modalities and technologies you use, that quality procedure can vary to the large extent. So rather than we have a specific QA checks, we need to have a good understanding, a true understanding of quality assurance principles, which is far more important than individual quality assurance tasks, which is important, more important than almost any other area of radiotherapy. So we need to look at the big picture of this elephant. So the main take-home message here is for our strategic quality assurance, I rather say quality management principle, which is related throughout the patient journey. I started from pre-simulation, the motion management on the mock-up scenario, and the CT simulation and fusion countering, and treatment planning, and patient-specific QA, and patient setup and RGRT, also treatment delivery and the follow-up, and all this feedback loop for the retreatment and the follow-up scenario. This our quality assurance, quality management process is crucial, not only that patient-specific QA step here, but throughout the patient journey and the radiotherapy chains. So start with the immobilization first, and then stereotactic area, the SRS, the brain lab as an example with three-part mask is quite crucial to firmly fix not only the anterior facial area, but also the back of the head to be firmly fixed, which will minimize the intrafraction motion. A saber, the vac bag, is the necessary item to fix the body with for the same purpose, and the CT simulation and the secondary image acquisition, such as MR and diagnostic CT or PET-CT. Ideally, we desire to be acquired on the same day or the same anatomy condition. And that's in that context, the patient preparation is crucial as an upstream issue, coupled with immobilization. This is a really good example, have a firmly fixed, nicely shaped of the back of the head, as well as the thermoplastic mask anterior face, which is firmly fixed, minimizing the internal motion. And also when you look at the patient preparation, if the tumor is abutting a critical structure such as heart, and we should triage what kind of patient breathing the states is the ideal for the given lesion treatment using stereotactic approach to create more space between the lesion and the critical structure. And also the bowel condition, here's an example, whether this is really good case or not, given the lesion location inside the liver. And also the lesion here, the budding, the sacrum here, and also how much the bowel prep and the bladder prep is required, which is very important. The aim is not only the reproducibility, which is important, also how we can maximize the therapeutic window. This proper ideal patient preparation immobilization can remove the issues down the track, such as image registration and contouring planning and IGRT and treatments. So once the patient preparation image acquisition is there, the image handling is very important because our PTV margin is now close to our slide thickness. So this is a good example of this single image. The VAC bag is well included here because even extended field of view, some of the VAC bag it may not be, it will be chopped off, not be included in field of view, which need to be dealt with correctly, such as avoiding the beam entry here. And then the importance of this secondary images, it's image resolution. It's highlighted here of this isotropic 3D spacing for the MR, and then one particular direction is very close resolution which limits us to define the urethra, which is inside the prostate target. So the good preparation and the robust immobilization, also the proper handling of the images is crucial, even before we get to our planning, which is part of our quality assurance program. The handling the images does matter because it is a typical example from our teams. About 20% of the 40CT requires some sort of the intervention related to artifacts. Okay, typically reconstruct or put additional margin or the rescan and etc. And there's a paper here from the Green Journal, Seco et al. And it really highlights that the bad 40CT impacts the local control in the moving lesion. If we actually stratify with the moderate artifact to the severe artifact, actually it can have a really statistically meaningful the tumor control. And then good image handling is not only related to moving lesion, but also the contrast. A lot of our SABR and the SRS planning images requires contrast to better visualize the tumor, which is inherently located in the low contrast area. If you don't handle that properly, the contrast won't be present in the treatment, which can have a meaningful and noticeable dosimetry error, which will be carried along from very upstream all the way down. And that not only the contrast, also our implants, which we actually require for our IGRT and motion management during treatments. And image distortion, we cannot ignore this, because the SRS, our PTV margin, is really extends. It's close to even greater than, or even less than our known the MR distortion issues, because it has to be properly dealt with and corrected, depending on what your MR and strength, and then your software correction methodologies. And contouring, now we have our PTV accuracy, PTV margin, also our accuracy demands a couple of millimeters, and then you need to know your treatment planning system and the image handling software can deal with correct margin expansion in the for example, 0.5 millimeter step size expansion is accurately created in your treatment plan systems. There's a quick example of the variant solution, which is the Eclipse, and compared to our elements, two different treatment plan system can have drastically noticeable volume changes, especially apart from the every millimeter integer expansion. When you go down to 0.5 millimeter expansion, one plane system cannot handle better than the other. So this is example 1 to 2 millimeter, and the magenta is 1.5, and it's really chopping on and off between 1 to 2 millimeter. And so depending on treatment techniques as well, and if you often more institutions now implement single ISO multi-target techniques, which inherently demands a larger PTB margin, because the same extent of geometric discrepancy, it can have a larger offset in the lesion further away from the isocenter. So if you start from the 1 millimeter margin, we have the comprehensive review. We call the inner zone and outer zone, which is cover most of the lesions per patient. Now skull is 15 centimeter or so. So it's a two zone. If you divide it for the simpler example, in the outer zone, we require additional 0.5 millimeter margin if the lesion is located further away from the isocenter. And then contouring the spine saver as an example, but it is applicable to all the other areas of the stereotactic tumor stream and the indications. Spine, a typical PTV margin expansion 2 to 3 millimeter. Spine chord should be defined in our secondary images because we cannot really see in our planning CT. We have our planning. The PRV structure typically expands 1 to 3 millimeter. And if you don't have MR, we use spinal canal directly, which will overlap with our PTVs. And all of those organs at risk and the complex, the target structure needs to be very high resolution to have a correct contouring as well as the expansion. And the image registration does matter because with the given limited resource, we have that should be very crucial part of our quality assurance. We'd rather spend more time in this upstream issue. If that's wrong in this example here, the PTV margin is 1 mil, and then that geometry offset image registration error is greater than PTV margin. Then all the downstream process can be affected, regardless how much effort you put on, if the upstream issue is wrong. So the SABRE example in the spine, yes, we really need to prioritize where to focus on. We need to locally match around a volume of interest, which is at the junction of the spinal cord to the targets here. We prioritize spinal canal accuracy and the translation rotation. It is required. And review all planes to get the rotation and correct to have a very accurate definition of critical organs abutting or wrapped around our targets. And another message here, often the misnomer is that 3D PET-CT can be used, which is true for non-moving lesions such as head and neck or the brain. But the 3D PET-CT cannot be used for the moving tumor target delineation. The reason is because it's not big. The issue with the PET. PET acquisition is order of minutes, so it's inherently quite robust to capture the tumor excursion for the high activities. But the issue is the 3D CT, which takes about 10 seconds or less as a snapshot of our breathing cycle for the tumor anatomy excursion, so which won't be matched well in our PET to CT. It's a good example here with a famous dumbbell-shaped stain. Most of the time, the both ends exhale and inhale phases. Therefore, but whereas the CT showed a snapshot of those tumor excursion, so overlapping index is only 30%. For the same patient, we take the 40 PET CT and reveals the better agreement of the CT to PET. So the take-home message here is that 3D PET CT cannot be used for the moving tumor delineation. So the SABRE stereotactic approach is highly conformal, a small field. So comparing to our conventional radiotherapy, the margin is close to the penumbra. And the homogeneous PTV dose, the maximum dose, we try to limit less than 110%. Anything over 107%, we consider as a hotspot, and they'll fall off outside PTV. So whereas it's a tactical approach, we inherently make a heterogeneous dose distribution by pulling those max dose up, and then we can have the even further sharper dose gradient. Therefore, the max dose is typically 120 to 130% of the prescription dose here, and the fall off outside is very fast. Also, it's often non-isotropic. So this is one of the take-home message that inside the PTV is not only heterogeneous but also much greater than 20 to 40% greater than a prescription dose inside the target in the middle of the PTV here. So we try to avoid the ring of fire, that the hot spot at the edge of the PTV, which is an example here. The aim is we try to avoid the ring of fire. We try to maintain the concentric hotspot. Therefore, we achieve the concentric dose increase from outside the PTV to the center of the PTV, shown example in the SRS as well as SABRE in this example. So how hot is the hot? So this is from the Red Journal Onco scan from the last year. So biologically effective dose 100 gray is merely a bare minimum we actually require based on our clinical evidence. So how hot is hot? and it's how hot is acceptable hot. Well, we have our pyramid experience over the decade. This is only the 5 years snapshot, purely to compare to our values, which is referring to a single fraction arm long saber trial. We achieved the near minimum. It's not just the absolute minimum. According to ICRE 91, we call near minimum D99 to D98, which is achieved 28 gray. And the ITV, we further increase the 33 gray. So already we see 130% increase there. So hotspot is the near maximum, which go even further up, up to the 140% in ITV as well as the PTV. So the value of a hotspot, so it's not really reported correctly. What we report is a prescription and the coverage conformity index of the 100% of the prescription dose. But the hotspot and location hotspot, the extent of the hotspot is not well captured and reported in the clinical outcome. But this is the common practice in stereotactic therapy, radiation therapy practice. Yes, we achieved a consistent high BED, 100 gray, the bare minimum. When you look at the inside, the hotspot, it goes beyond 100, even 160 gray, 165 gray in ITV. Even the near minimum dose, D99% coverage in terms of BED is over 100, and ITV mean dose is over 140 gray. So in terms of treatment planning, center placement is crucial before you look at the plan and dose distribution and plan quality part of your plan evaluation. Often we put the isocenter in the middle of the PTV, which is not the case all the time. I take an example here, the multi-med single iso technique. We want to put the isocenter roughly in the center of the entire all target masses. And this is, we only try to make a uniform dose. I try to have a zero or minimal dose inside. The metal blocking is not a new issue, but it's our classic issue. It's directly applied in our saber spine. Therefore, typically we put the isocenter at the junction here between the spinal cord and the PTV. So it really helps us to further achieve a higher the rapid dose fall-off between the target, the critical organs, such as spinal cord here. And energy selection for vertebral saber as an example, you can see our distribution from our Peter-Mac we treated for the last decades. The energy, we use a 10 triple-F to maximize the dose rate modulation, also treatment time efficiency, but we still use 6 triple-F for our C-spine in the neck area. And what makes a good plan? SRS, when you look at SRS, typically we require 3 to 4 arcs, 120 degrees or longer per each arc. So in the total arc, the minimum should be at least 300 degrees as total. Then when you look at the conformity index and also the gradient index is just the ratio of the conformity index, 50% isodose line volume to the 100% isodose line volume. It's a ratio really, it depends. It is a function of the PTV size. And then we have the 4 groups as an indicator, as a quick snapshot to actually efficiently pick up necessary the poor conformity, which really the gradients index we get poorer for the smaller volume because the tumor volume itself is small. It's harder to make a tighter coverage in relation to its tumor volume. So typically most of the tumor that we can cover in the range between 4 to 8 in terms of the gradient index. And what makes a good plan to continue? And this long saber cases, interplay does really matter. Yes, it does matter, but only it is really matter for the single triple combo of the single fraction and it's a heavily modulated and triple F those fast dose rates area. And the saber spine demands the highest complexity for given nature of the geometry. And we typically, even if we don't need many arcs, with the two full arcs can make a decent plane with combination of the collimator around plus minus 5 degrees from the zero. We don't use zero because we don't want to accumulate the interleaf leakage in the single plane. And with second arc, we will swing the collimator to 90 degrees, so we can effectively shield the chord while opening the MOC aperture to the targets. So we mix those two different collimator configuration for the two full arcs recipe in Spine Saber. And then the VMAT complexity, when you look at our different plans, when you look at the modulation factor, which is a number of monitor units per centigrade, and without affecting the plant quality, we can actually reduce the MU quite effectively. What that means in the other way around, we don't really often insert a stochastic approach. We don't need very complex plans, unlike the long course fractionated head and neck, as an example, in opposite end. So the conformal arc or even the reduced complexity MU suppressed the VMAT approach we call robust VMAT has a nearly almost same as the conformal arc in terms of the plane complexity and the modulation. Can achieve the decent plane without compromising too much. So is there any dosimetric trade-off if you have the robust the VMAT with the MU suppression? Yes, it heavily reduces the complexity. It's the dose distribution. When you look at the CI50, for example, it starts bulging out without affecting. So often the highly modulated plan may not be deliverable, not realistically deliverable plan. So also what that means, dosimetric uncertainty is increased with the interplay and the larger average the leaf opening, leaf pair opening. We can make a plan more robust and less time to iterate planning, and also shorter treatment time, especially coupled with the motion management. And reducing the maintaining low complexity plane is not only the lung saber. This quote is from Matthew, the research physicist. And even the abdominal, the kidney area, we try to make the bowel loop here. So the streaking of the intermediate isodose line doesn't need to streaking through the bowel loop. So without really affecting the plant quality, significant reduction of the complexity can be achieved with a very little dosimetric compromise here, with number of the plant scoring metrics. And this is we move on to saber spine, the same story. When you score with a certain set of the metrics, and then so more complex plan can ideally then achieve the higher chance of plan being dosimetrically superior, but you really don't need too high complexity plan to be a good plan. And the scoring, when you see here, there's a similar scoring with a wide range of the variation in terms of the plan complexity metrics, such as MLC gap or match metrics here. So the take-home message across the body sides, we really don't need a very high modulation or plan complexity to achieve a good plan. This is our saber spine in terms of the modulation factor distribution and ALPR, and based on our experience, modulation within 5, which means our 20 gray single fraction spine, the less than 10,000 MU, can achieve decent plan, which will be associated with average leaf pair opening, which is our average field size, aperture size greater than 10 millimeter for the 2-4 arcs recipes I mentioned before. And then what makes a good plan here? This is our isodose, 100% isodose line. And then this 120%, the hotspot should maintain inside the GTV, shouldn't should be located adjacent to close to organs at risk. When you look at 50% isodose line here, they should be wrapped around another other clinical or critical organs such as esophagus. And then the spine, we don't really try to cover 100%, which is impossible because the PTV is always overlapped. with the PTV. So D90% should be covered by 90% of the prescription dose, and then have the rapid dose fall off should be greater than 2 gray per every millimeter, which is achievable up to 3 gray per millimeter for the single fraction 20 gray regime. And then a quick word on the maximum dose constraints here. So depending on fractionation, we have different tolerances, which is 1 to 5% risk of myopathy in context of spine saber. But the ICLE 91 recommend somewhat similar to near minimum of the D98 or D99 coverage, or near maximum as a D2% as a hotspot definition. Now, for the D max of the point max, it's discouraged. Rather, we have 0.03 cc as a more robust dose scoring to reduce the uncertainty on the dose scoring there. When you look at your systematic difference compared to true max point dose to 0.03 cc, it's about the 1 gray differences there. Similar to the 0.1 cc, the 1.6 gray difference to the point max. So we always recommend the 0.03 cc as our standard practice, but you should be aware that with the clinical treatment planning system can record that directly. And we're moving on to planning dosimetric, the validation. The end-to-end dosimetric test of the independent audit is mandatory. And for the specifics coupled with small field, it should be always coupled with your clinical imaging procedures, such as the cone beam, as part of your IGRT in both SRS and SABR regime. So our treatment delivery verification includes physics and RT therapy plan review and calculation-based methods. We use mobile 3D and FX, including 3D gamma and DVH comparison and the point dose measurement with the small field detectors, such as CCO4 and microdiamonds. And we also do 2D 3D array, such as arc check and SRS map check, which is quite useful for SRS and spine saber. Or Delta 4 is also another popular solution. We often measure the film as our standard, which is very useful to capture the sharp dose gradient. And for our routine patient-specific QA, it's hard to measure that when using a heterogeneous material. So we developed this the solid water. We can measure any 3D planes. We compared with the SRS map check. For the film insert, which has that 4 pinpricks that incorporate the IGRT procedure. So anyway, the review is very critical, as I mentioned. When you look at for the last 40 months, we actually measure every other one case each week. Therefore, the quality assurance, if efficient quality assurance or the effective method is quite important. So we measured the aforementioned small water phantom, and that actually can measure concurrently the film and the microdiamond. And we reviewed our gamma passing rate with different passing criteria for 5% 1 millimeter and 3% 1 millimeter, as well as microdiamond detector in the same measurements. Typically gives within plus minus 1.5% confidence interval. So when you analyze that, 218 has a statistical analysis recommendation. We can have the 20 plans to model and another 20 plans to validate. Or take home message is here, depending on your techniques or depending on your detector choice, your action level and tolerance level can vary. Instead, because your spine saber have a different passing rate for the same detector compared to the long saber or SRS, for example. Also, for the same treatment indication for SRS, 2 different detectors may have a different tolerance levels, even though are very close to each other. So, and last, this is the IGRT procedure, and then your system should be well it have an appropriate action level in our SRS, and also Saber spine. We use our exact track system for 6 degree of freedom correction to correct the intraflexion motion for individual between the arcs and beams. Action level is a 0.5 millimeter, 0.5 degree, and our cone beam for the soft tissue matching and the lung or abdominal area, zero tolerance after initial cone beam. And after, is there greater, so for the following cone beam method, additional requirement to correct 2 millimeter or greater, and that the re-image is required to verify that. So in summary, stereotactic radiotherapy include both SRS and extracranial. Saber is a safe and effective approach in nearly a mature treatment regime now, and obvious trend is moving to the single fraction, even to 2 fractions. So in the safe, effective stereotactic program requires stringent imaging and registration and control protocol. Even when you look at the plans, it should be part of your QA quality management process. The treatment planning requires modulation to avoid hotspot near organs of risk, avoid ring of fire to maintain the hotspot in the middle of your target, and to achieve the high dose gradient to irregular target shapes, and your pre-treatment verification measurements, and useful only with appropriate tools and analysis. And as a last take-home message, quality assurance is required throughout the radiotherapy chain, not only the pre-treatment verification measurement, but from the upstream issue, it's better to spend more time. Okay, this is the end of our talk. I will be available for a Q&A. I hope you enjoyed the session, and I'm happy to answer any questions. Thank you.
So, Dr. Adam, thank you very much for the presentation. So, who have questions from the audience? So, I have a question that you mentioned couple of gadgets for the QA, but I don't see the portal dosimetry. So, is there any specific reason of using this map check for the 2D fluence comparison as compared to the portal imaging?
Hi, can you hear me okay?
Yes, yes,
Probably I can't turn on my video on.
yes.
Turn on my video. Yeah. Yeah, the portal dosimetry is a really good option to use, quite efficient. But one of the pushback was it's not from the patient coordinate point of view, it's still in the machine. Especially the multi-mats we try to measure in a single plane, it's hard to decompose which part. In the worst case scenario, if something goes wrong, it's hard to decompose which component is wrong. You still have to measure if it's wrong. So yeah, but there are a lot of studies now. We're getting convinced it can be sensitive to detect certain errors. It's like even the single mat, the multi-mat singleizer techniques, it can be useful. Yeah, I agree.
Okay.
But somehow it's more cumbersome to calibrate accurately with the triple F beams, I think. Because it's ideally designed for the flat beams. Most of our stereo use triple F beams for fast high dose rate.
Okay. So then regarding this mechanical accuracy, which system are you using up there in your center for the daily mechanical accuracy?
We have more tolerance than what the vendor is saying. So we do half mil, half degree as bare minimum.
Okay.
Yeah. And
but what's the system name? Is this is something from the machine side, or you have purchased something from the dosimetric side?
the mechanical accuracy.
Yes, yes.
No, we use our MPC from variant solution, the machine performance check, and our Vincent lots
Okay,
with
so
standard BBs and then typical imaging phantoms. So we have a set of commercial and in-house developed 3D printed phantoms.
okay,
Yeah, but to be honest, yeah, for example, commercial solution like SNC solution for multi-mat Vincent lots, I think that's pretty good.
okay,
So after connecting to the question, I see a bunch of questions there. Yes, regarding the mechanical and IGRT. Yes, a lot of centers they don't have the exact track that IMAP solution, which I believe personally is very well optimized for SRS with couch kicks. Otherwise, you cannot do the good imaging for the intrafraction motion. But I think the hierarchy, like you guys know, certain fixed couch geometry with 45-degree on 90 to 70, you can still image with OBI. So our still recommendation, based on our the experience, yes, Abnav is a good example. Like we still better image at that trading position, which means with that non-coplanar couch angles. So we did see that quite a significant intrafraction motion. But when I say significant, it's all related to PTV margin. If you have 1 mil margin, half mil off, it is significant. If you have 1 centimeter margin, even 1 millimeter, it's not significant at all. So it's all relative to the PTV margin where you put on. And because I'm aware that even a lot of half of the SRS wall, they go with no margin recipe like a gamma knife. In that case, anything less than half of your margin, you can miss out 30% of coverage.
okay. So we have a question from audience.
I'm Khalid Iqbal. So what about the Winston's accuracy in your center? What is your experience? If the Winston's is pass or failed, what is the action level? Do you deliver the plan or what type of action you can take at in that moment?
So the specific question with the QA results from the Vincent Lux test.
Okay. Yes.
Yeah, we apply the 1 millimeter, which is, yeah, we have different definitions. When you say 1 millimeter, is it radius or diameter based on what types of test fields you created? Yeah, so we limit our 1 millimeter radius, which is somewhat forgiving, because as you know, we have to be pragmatic at the same time. Yeah, so we limit to the 1 millimeter as our action level. If it's anything greater than that, we don't treat, which is a luxury in our center, to be honest. We have 6 linear accelerators. So one machine is down, we can treat the other machines. So I understand if there are only 1 or 2 machine centers, that's not really a pragmatic solution. But yeah, we do limit 1 millimeter action level for Vincent lots. But having said that, Vincent lot is not everything. So we get that with the treating worst case scenario, if you have a treating arcs, it's not specific IMRT type, it's the entire arcs you're going through. So arguably it can be acceptable if 1.2 millimeter Vincent lots results against 1 millimeter tolerance. It's hard to draw the line purely based on the Vincent lots at the isocenter, to be honest. Yeah. Its action level is not the absolute tolerance not to treat patients. Yeah.
Not absolute call. Okay. So we have a question from one of our colleagues who have joined online. So a center they do have a cyber knife and a true beam. So they are asking your expert opinion that which one would you prefer for which modality? I mean, for Saber or for SRS?
So CyberKnife, if you have it in your toolbox, is excellent tool. Yeah, I'm not an expert. I had that only fellowship experience with CyberKnife, but we have our neighboring site does have, and it has a certain advantage dosimetrically, and it has the tumor tracking option. It's good for the Saber, And then, but everyone's aware, if in busy centers, probably some of you have very busy, large patients, that it takes a long time. So I'm a physicist, the scientific point of view is very attractive and sexy. But if I put my executive hat, I won't buy that for the patient throughput. So if like my center is a largish center, we have 6 Linux and then planning to put 1 Proton, 1 Gamma Knife, Rack, etc. It's really good to have in part of toolbox. But this smallish, medium-sized center, that will be quite luxurious to do. So yeah, one can argue if you prioritize patient throughput, it's not attractive. But if you really getting specific patient cohort to treat, you find very hard, challenging those distribution, like a second spine, for example. And then it's really valuable, yeah. But I don't think the SRS, you can say Cyberknife is better than Trubin. We can say it's equivalent, but it can meet all the required those constraints and conformity.
Good. So we have a question from our lead therapist.
Dishan. My question is regarding the patient setup. As you have mentioned, the exit track system. So is it a must, or those who don't have this can still go for Sabre or SRS?
Yeah, ideal scenario, if I have unlimited resources with the money balance, yeah, I would ask to buy exact track, but I know the majority, the 2/3 of the world, that they do SRS without exact track. So it can be done. So because with a 6 card, if it's integrated with your machine, the combing can be done, but the only recommendation is it's better to image at that treating card chambers. So some card chambers you cannot do with the direct OPI imaging, but it can be done, yeah. So I don't think that's absolute requirement. So in our number of clinical trials for SRS, SRT, we don't put as a mandatory, but we do the desirable. So we put a requirement, capability of imaging at the treating angle. We don't specify commercial solutions, but just a requirement as a final clinical practice.
Okay. So one interesting thing which we just observed in your slides is that you are treating most of your patients with 10 triple F, correct? Instead of 6
That's
triple.
correct.
So
You mean?
yeah,
Yes.
it's opposite here at our side. So what about the neutron fluence in that specific scenario? Are there any studies? Because at 10 triple F, I can understand that's just a soft beam, but still, are there any studies or how systems are incorporating this factor?
That's really good and important radiation safety question. Yeah, because before all our traditional understanding, 18 MV neutron factor, anything 10 or less, is kind of negligible, which is not the case, as the newer study is showing at the lower energy, such as 10 MV, we might be better to consider neutron contribution. But acknowledge that there's no extensive neutron contribution study on the SRS dose rate scenario comparing 10 triple F and 6 triple F. But the question is, we want to use flattening filter free beam to maximize the dose rate, not the efficiency, also full modulation during the treatment. But between 10 and 6 triple F neutron contribution on that high dose per fraction scenario, I don't think there's much studies done.
All right. So one last question from audience.
So my question is regarding LINAC based SRS or Saber. When would I would like to let you know about that our experience at our institute that we are when we are treating the patient and before the treating we take the image MVKV and then the CBCT and the MVKV limits are different, I mean, the shifts are different and the CBCT shifts are different. What is your experience at your center? How you can treat the patient before actual treatment? How do you take the imaging?
Yeah, so we do the initial KV imaging. We don't do KV-MV imaging most of cases. But yes, KV-MV orthogonal image is required if you don't have the exact track, or you have to take the image with OBI with couch clicks. But yes, we always track the trends, the agreement or disagreement between KV planar imaging results and the cone beam. So because if you KV compared to cone beam, they should be identical, with the same coordinate is being shared. And the KV isocenter to MV treatment beam isocenter, it may not be zero. They might contribute to that results, the discrepancy between KV MV imaging and the cone beam. Yes, so if there are more than half a mil difference, it's very alarming in the context of SRS treatment.
So,
So we aim to make it everything within half a millimeter.
so when you take the KV image, do you apply the shift and then take CBCT, or just
Yes, a zero tolerance.
take MBKV and
Yeah, we have a zero tolerance policy. Whatever shifting you see, we apply. Then we do the cone beam, and whatever you shift displacement you see, we do apply. And then, but the difference is if that shifts a online couch correction greater than 1 millimeter, we do re-imaging. If it's less than 1 millimeter, we still apply without imaging in between. So the zero tolerance policy, but whether we do re-imaging or not, yeah, that has an action level.
Well, thank you very much. So we'll just move towards the next agenda, which is the case presentation by our head of medical physics, Mahanas Kanwar. So she will be presenting 3 cases briefly: brain, lung, and spine. So over to Ms. Mahanas.
Hello. Can everyone hear me?
I can hear you well.
Assalamu alaikum. Hello and welcome everyone. Thank you, Dr. Yo, for the excellent presentation. It gave us a few crucial points that we may incorporate in our treatment planning or look into very closely. So my main focus will be sharing our experience on the 3 sites that we mostly do in our SRS SPRT program, namely lung, spine, and brain SRS. However, just to go over some, sorry. Just to go over a few points. As Dr. Yo mentioned, the basics of treatment planning of an SRS SBRT treatment is to deliver very high ablative doses to the tissue within the PTV, while at the same time sparing the surrounding normal organs. And again, as you mentioned, the maximum point doses inside the PTV can reach up to 140 to 150% of the prescription dose. And those high doses can only be delivered safely and dose to the normal tissues minimized if we employ highly effective immobilization and incorporate effective motion management techniques, especially like you mentioned in case of SBRT sites like lung and liver. So just a little bit about our experience. We're nowhere near you guys, but we started our first SBRT. We started our program with an SBRT in May of 2020. First SRS brain in July of 2020. And since then, to date, we have treated total SRS or SRT brain 146 cases. SBRT has surprisingly caught up, and we are up to 144, of which we have 29 spine cases, 23 lung cases, and total, if you look at the total, we have treated about 290 patients. And other sites that we have treated include liver, nodes, prostate, non-spine bony metastases, and kidney. The machine we use for our SRS, we have a variant with HyperArc and HDMLCs for both the SRS and SRT cases. And as a backup, we have another TrueBeam with 120 Millennium MLC, which is acts as a backup if our SRS specific machine is down. The treatment planning system we use, we recently upgraded to version 18. Before we were using 15.6. So one of the things we are really careful of, and before we start any SBRT new site, is we want to ensure that we have site-wise protocols and evaluation forms, because we are a very busy center. On our SRS specific machine, we treat about 50 patients. And before we treat those patients, we have about 2 to 3 SBRT cases on a good day. So we have developed, and we have a bunch of our team involved in this, and just to ensure, and a few of our consultant physicians. So we want to ensure that when we're delivering these treatments, we are following certain protocols, and ensure that our prescription and OAR doses are within the guidelines. So the protocols we have referred to coming up with these forms are the UK SABRE Consortium guidelines, the NRG RTOG protocols, the RTOG for the brain and spine, for lung, and we have referred to TG 101 and the Timmerman tables. And for dose reporting, we use the ICRU 91. So these publications specify detailed requirements for treatment planning, dose prescription, and target dose coverage constraints and dose reporting. Since we'll be discussing the 3 specific sites, namely brain, spine, and lung, at our center, the most commonly used doses for brain is single fraction. We do 15 to 24 gray. Again, specifically, that's based on the size or the diameter of the lesion. And for surgical cavity, 12 to 20 gray, again, based on the size of the surgical cavity. And again, we use this same rationale to fractionate when the 12 gray dose to normal brain in a single fraction exceeds 10 cc, then we fractionate. The fractionations we use most commonly are 24 to 27 gray in 3 fractions, and 25 to 30 gray in 5 fractions. For spine, as per our protocol, we use 16 to 18 gray Most of our spine cases, we have been able to do with 18 gray. That's kind of our standard single fraction dose for spine. 3 fractions, 24 to 30, and 30 to 35 for 5 fractions. Lung, we use the 54 gray, 3 fractions, 54 gray, 5 fractions, 55 to 60. And recently, like you mentioned, there is a greater use of single fraction SBRT since really after COVID. So recently we treated a first lung patient with a single fraction of 30 gray. So we treated about like a couple of weeks ago. So I mentioned the safety and evaluation form. So I'm not sure we can see it really clearly, but these are the site-wise evaluation forms that we have developed, which actually have the prescription doses, the tumor volumes, the OAR doses. So we have come up, with these, consulting all these different documents, we have come up with a consensus and came up with these forms. This is an example of an SPRT lung evaluation form. And these dose fall off table is from the lung RTOG protocol, which we actually find useful, and we use it for almost all our SBRT cases. This is for our spine. Like I mentioned, we use that form, the spillage and dose follow-up form from the lung protocols. It gives us a good idea about our spillage. And this is an example of our SRS brain form. These are some of the checklists when we, this is after the third part of our workshop is an actual demonstration of patient and machine specific QA. So before the second form, this is a pre-treatment patient specific QA. Like Rafi had mentioned a bit earlier, we use portal dosimetry and a point dose patient QA at the moment. We don't have an independent array system for that QA, but we do that. And also, before we start the treatment, we have a pre-treatment checklist that both the therapist and physicist go over before we actually start a treatment. Now, this was just the basics. I will actually log on to our Eclipse planning system to go over a few of the plans. The first will be a lung case, the single fraction lung case that we recently did. Yes, sorry, just bear with me, please. We're just moving between screens. So for lung, we are equipped with, as a motion management approach, we use the 4D CT. We may use the 4D CT with amplitude gating, phase gating, or sometimes even breath hold. For this patient, we did a 4D CT and tried to assess the motion. And we found out that there was quite a bit of movement in this case. So I will go to image registration just to show the motion that we observed. And our criteria here is any motion, we include the phases where the motion is 5 millimeter or less, and then gate the beam for the rest of the phases. So we can see once I play, we will be gonna turn off some extra. So this is the final data set we came up with. You can see the tumor is in motion and we have the ITV around that. But these are the phases that we selected. Before that, before we selected the phases, I will show you how the tumor motion was. So this is this full extent of the motion, and then this was a very interesting case because when we did the average, we first thought that we had made some mistake performing the 4D CT because the way the tumor appeared, it basically appeared like a vertical sort of rod. And then we figured out that was because of the motion of the tumor. So you can see that's the average. And when we look at the MIP, which is the maximum intensity projection, so that's how the tumor appeared. There was so much motion. So like you said, quality assurance is important at every level, starting from, when the patient comes in and we go through the MDT to select patients and right through the CT and imaging studies and until the treatment process. So we went in, we ensured that our imaging was correct and we saw that there's no images missing, and this was actually a good 4D CT. So then our physician determined the different phases where the motion was more than 5 millimeters, and then drew ITV by drawing ITV on each phase. And then having an accumulated ITV on the average. So we figured out that we basically, there was too much movement, and we drew let me open the average. I'm sorry, the screen here is appearing very small, so I'm having to scroll a lot. So then we made a plan average. And based on the motion of the tumor, the phases that we chose to treat this patient in were 0, 10, 20, 70, 80, 90. So we basically gated out the 30, 40, 50, and 60% phases. And then we came up with this average. So we can see that the ITV, this is for the specified phases, and that's how the tumor motion is. So then our physician went ahead and gave, because we are accounting for the movement, and since there was a little bit more movement, craniocaudal, our physician, just as a precaution, went ahead and gave a 5 millimeter margin, which is our standard all around the ITV, the accumulated ITV. And then just to be on the safe side, a 6 millimeter margin, we usually give 6 to 7 longitudinal or in the cranial caudal direction. Any questions at this point? And then I will move forward to the planning section. So like I mentioned, this is our first single fraction lung SPRT plan. We routinely use, in case of lung, we use 6 triple F, and we use 3 arcs, 3 half arcs, basically, since the tumor is on the right side. We use 1 arc with 0 couch angle, and then the 2 arcs with about 10 to 15 degree couch kick. The advantage it gives us is basically it reduces the spillage into the lung and reduces the normal lung dose. And we get more or less a very isotropic dose fall off away from the PTV. So in this case, the normal lung dose. So what we do with the normal lung is, because that's like one of the organs that we have to be careful, or the way we come up with the normal lung is we subtract the ITV, the cumulative ITV volume from the total lung volume, and then we have the normal lung volume. You can see there is pretty much isotropic dose fall off around the PTV. And then there is a little under dosage here because the patient, the tumor is sitting right on the chest wall. So we don't really try to spare the chest wall, because in this case, the tumor takes precedence, but we try not to create any hot spots on the chest wall. So if we go by our evaluation form, the dose coverage that we expect in this case is for the PTV, 100% should be 95% or greater. So in this case, our PTV is 99, more than 99% of our PTV is getting the prescription dose. The other OAR that we're concerned with is the chest wall. Look at the ITV dose. So we're actually getting pretty hot inside. Usually, according to our protocol, our max dose inside the PTV for lung cases, we can go up to 140%. So in this case, our D2%, we do record the max and the minimum doses as per ICRU 91. And we have recorded these for all our SRS SPRT cases in our evaluation forms. Our D2% is 36.8 and our D98 is 30.4. Whereas our D max is not really hot because we had to cool down the plan a little bit to keep the chest wall dose under control. We do want to keep the constraint, the 30 cc, the 32 cc, the 32 gray to less than 30 cc for the chest wall. But so we can see that our ITV is actually sorry, that's the PTV, that's the ITV. So basically 99% of our ITV is getting 34 gray and 100% is getting 3379. Another plan objective in this case is our dose fall off or spillage. So we use that table from the RTOG, the lung RTOG, and which is based, the fall off and the spillage is based on the volume of the PTV. In this case, the volume of our PTV is about 6 cc's. So if we look at in that form that I showed earlier, at D2cm, the dose should fall off up to 50% based on the volume. So we look at the 15 gray isodose line. And our 2cm, we draw these concentric rings around just to give us an idea. So that's our 50% spillage. So that's the dose, and this is 2cm. So that's basically, according to the protocol, we're supposed to go below up to 50%. So we're way below that. In this case, the other concerning volume is the normal lungs. So this is our normal lung, and then the single fraction. For the single fraction, these are from the Timmerman tables. V8 should be less than 37%. So if we look at V8, so we are pretty good there as well. We're only 2.69% of the volume getting V8. And another constraint is the 950 cc. This was incidentally a female patient. And again, from the tables, we should be getting less than 7.2 gray to 950 cc of the lung volume. So again, we can see we're way below that. Other objectives for this are the dose spill. So another objective is the 105% outside PDV should be less than 15%, but we do not have any 105% outside the PTV. And I mentioned that a dose at 2cm should be below 50, and in our case, it is 36%. So there is really no other critical organ in close proximity. So this is our final plan. Any questions before I move on to the next one in this case? So I have a question from the audience. Is there any consideration to limit the target motion example using abdominal compression board? So we do not have it's a very good question. We do not have a compression board. We actually tried to get that, but we haven't been successful yet. We do have that, the belt, the compression belt. And initially, when we started a program, we did try to use that, and we haven't been really successful with it. We were unable to reproduce the setup really well. We tried it for a couple of our liver patients, and the patients were uncomfortable. So in future, we are planning to look for a compression plate, which I've had experience with at other centers, and those are much better. So no, at this moment, we did try for a couple of cases, but we haven't been very successful, so we're not using that. So we basically, when we do a 4D CT, it takes 10 phases. So then we determine in which phase the movement of the tumor from the median phase is basically less than 5 millimeter, like I showed earlier. So that's basically our criteria. In some cases, if the duty cycle of the curve is very low, and we're mostly because, you know, even though we're sparing the lung, it actually increases the treatment time. And before, like Dr. Yo mentioned, we can treat patients, a regular SBRT patient, about 45 minutes. But, you know, when we have these gated treatments, because we're not using the whole cycle, we're using almost like half the cycle most of the time, our treatment time goes up to about, 1 hour or so. So we have to, come up with a balance between the accuracy of the treatment and, the use of the gating. So, and the sparing of the lung. So in this case, we basically, the way we judged it in this case, one of the phases were even moving 6 millimeters. And since we wanted to at least increase the treatment percentage within the useful beam, so we use that. So yes, so we basically determine the phases based on the motion of the tumor, and our criteria is anything more than 5 millimeter, we will gate. We will not treat in those phases. Oh, okay. So since Mr. Rafi mentioned we have 30 minutes left, we will move on to our one of our SRS treatments. This is the first time we actually treated 5 METs with a single isocenter. So here at SKM, we have the HyperArc system from Varian. Again, there's no, I didn't mention it, but I have no conflict of interest. But this is the equipment we have. And so this is, so the HyperArc, it's an algorithm, and basically it has a standard of 4 beams. And I will show you the distribution of the beams. It makes our life very easy because we just, with a busy center as ours, it's easy that we don't have to play with the accurate angles. I've actually worked with Brain Lab before, and it took a while to come up with the good angles, but obviously once you're used to it, you can do that easily. But in our case, we know that we have these set of angles and we can just choose between those. And as of now, we haven't had any issues. So basically, in the interest of time, I'm going to rush a little bit. So we have these 4 standard arcs. And then we had 5 lesions. So in this case, it's a single fraction, and based on the size of the lesions and the fact that it is a multi-isocentric, multi-MET treatment, our physician prescribed to deliver 21 gray in a single fraction, and this is the distribution. So this is the first lesion, second lesion nearby, third lesion way towards the right. This is the fourth lesion. Oh, this is the fifth lesion. And this is the fourth lesion. So in this case, we were lucky. Our only normal organ that we had to spare was the normal brain. We didn't have any other critical organs nearby, like the brainstem. So we were able to achieve this easily. We can look at again, the 50% spillage. So our criteria is for, and this is from literature as well, that for very small lesions in the brain, our dose at about 1 cm, basically our dose at 5 millimeter to 1 cm should drop to about 50% and below. So that is what we achieved in this case. And the more important, if I can turn on those rings, just 5 to 10. I can show you this one lesion where this is one of the largest lesions where that's the 50%. We're not concerned over there because that's not the brain. And the most important thing in this case was the normal brain. So like I mentioned before, in literature, it's been mentioned that the symptomatic brain necrosis increases as the volume of the 12 gray isodose line increases. So we basically, whenever our criteria is, whenever the 12 gray is greater than for a single fraction, the 10 cc volume is getting more than 12 gray. The 12 gray is received by more than 10 cc, we fractionate. So in this case, we can see that our 12 gray, this is the normal brain, is 8.1 cc, and our limit is 10 cc. So we were able to achieve that. We can see that some of these lesions were quite close, but we tried to restrict the dose without increasing the normal brain dose and or underdosing the volumes. And we can see the coverage. Is adequate. It's actually a little bit more because we're treating 5 lesions, so we cannot have the exact dose and it varies a little bit. But we can get to the PTVs. So this is the total PTV. I guess in the interest of time, like dose to 99 is 2188, dose to 100 is 20. So basically for these lesions, we look at the dose to 99%. Again, just to see how the hyperarc works, because that's made our life really easy and it's an automated. I could not show this plan, so I made a copy just to show you how we select the beams. So when we select the hyperarc plan, it places the isocenter by itself and this basically the center of gravity of all these. So these are the options we have. These are the 4 beam angles. So one is a full arc, and then the rest are half arcs with a different couch values. So what this does is we can actually look at the actual dry run, the virtual dry run, and this is actually how the machine will go through between all the arcs. So that's the hyperarc mask. The hyperarc algorithm only works with that mask. This is the first full arc. And this is all automated. So we just press a button one time and then everything happens automatically. This is the second half arc with the couch kick. That's another 315 degrees, and then there's a complete 270-degree angle. The beam coming in through the vertex. So this is where we basically, this is how we input the plan. Any questions on this? Then we can move on to our third and last case. Okay. So moving on to so this is a spine T10 lesion. We usually employ, most of our treatments are delivered at 18 gray single fraction and to the 80% isodose line. And sorry, I forgot to mention the prescription line that we start with is in 80%, and usually like with Linic, SBRT, usually the isodose line prescribed to is 80 to 90%. Sometimes we go down to about 79% when we need a faster gradient, a sharper gradient in some cases, and we're unable to achieve our spillage and fall off requirements, but usually we start with an 80% prescription isodose line. So this is, and for all our SPRT treatments, we also use the 10 triple F beam. The advantage of which is that, there's the treatment delivery is faster. So in this case, so this is this PTV. Turn off. The PTV. Usually our margins are anywhere from 2 to 3 millimeter. And we use the same margin, whatever we are employing for the PTV for our PRV for the cord. And we look at the dose at the PRV. Again, like Dr. Yo mentioned, another quality assurance part of the planning process is the fusion, because almost more than 50% of the time we're drawing the volume on an MR image. So we have strict MR protocols per site as well, which is defined in our protocol, and we collaborate closely with our radiology department. We have set our certain protocols that we know, like if we have an SRI sprain, we will specifically mention that please use that specific protocol, and then they would use it. We have different protocols for example, liver and spine, and we ensure that the quality of the imaging is good. Sometimes we've had to repeat our MRI scans to ensure good quality. Also, another step in our quality assurance is when the planning physicist fuses the MR before the physician can review it, an independent check is done of the fusion, because fusion is everything in this case. We're drawing delineating the tumor on the MR. So we ensure that the fusion is reviewed by a second independent senior physicist before we get it approved by the treating physician. So in this case, so for spine, the PTV, because of the close proximity to the spinal cord, the coverage, we're allowed to have between more than 90% of the PTV covered by 99 to 100% of the prescription dose. And the PTV, as per the protocol, we can have up to 80, down to 80% of the volume being covered by the prescription isodose. So in this case, you can see how the volume is around, the dose distribution is around the cord. We're actually, it's basically surrounding the spinal cord, our isodose line. In this case, our only OAR, in this case, organ at risk, is the spinal cord. We look at the doses on the PRV. And our max dose point, which again, as per TG 101, is 14 gray. So if we look at the 14 gray isodose line, you can actually see a hole right in the middle of the isodose distribution. That's the 14 gray. So that's like the max point dose limit for the spinal cord, which we use the PRV to look at. And then the volume constraint is less than 0.35 cc's, should be less than 10 gray. And we achieve that as well. But just trying to show you how well the optima, and actually Dr. Yo mentioned just now that they put their ISO center very close to the cord and it gives them a good dose fall off. We will surely try that in our next spine treatment. And another one is using 90-degree collimator angle. So those are good points that we got from you today to have a better dose fall off around the spine. So if we look at our CTV coverage, so this is our CTV. So we're getting 95% of the volume getting the prescription dose. PTV, sorry, this is the PTV. 95.4% of the volume is getting the prescription dose. And this is the CTV, where more than 99% of the CTV is getting the prescription dose. Any questions? I'm just going to leave more time for the questions. Any questions from the live audience?
Only challenge for the breathing pattern of the patient, because the first 40 CT, the patient was breathing too much deep, and the motion, too much motion was more than that we required. So we have to restart the patient and read the 46 CT, then we got the right position of the motion, the right breathing pattern.
So Mr. Zishan, he's our lead therapist. He brings a very good point. And like I said, this starts from the quality assurance part of the planning process, starts from the MDT, and the technologist in the CT room play a big part. And basically, another criteria, a very important criteria, is the selection of the patient. What kind of breathing pattern, because every patient is going to be different. Not everyone is going to have a stable breathing pattern. So we have to select. Sometimes in one lung case, the patient's breathing pattern was so abnormal that we could not, we could not do a 4D. So we had to do it in breath hold, a deep expiration breath hold. So we had to do that on a breath hold, a CT, and we did it that way. Some cases, if the motion is less than 5 millimeter, then we treat with all the phases and the motion is factor. So yes, the patient selection plays a very vital role in delivering a good treatment. Thank you, Zishan sir, for the input. Yes, Dr. Yo. Sure. I do.
Thank you, Manas. This was comprehensive overview of the three cases. So, Dr. Wu, so we just got your message that if you want to share some of your SRN and SPRT protocols and a few tips, please.
Yeah, I think I shared my email. Anyone wants to look at our department protocol, we're happy to share that. We often do that. We are variant-based center. We run motion management workshop, the inaugural workshop in our area. So we host it under variant name tag. So we're happy to share any wisdom and tips based on our experience. Yeah.
This is Manas. Doctor, do you have any critiques about those plans we showed you? Anything important specific to those plans we would like to know?
Yeah. So regarding motion management, yes, typically the most of centers a lot of countries in the globe, they use 1 centimeter as a tolerance. So it's not hard rule. Anything greater than 1 centimeter, we start considering motion management. Or anything less than 1 centimeter, we may not, but it's not really absolute tool because it's all around isotoxic approach, which means we try to meet those constraints to the surrounding organs at risk. Then while we're keeping, then we try to boost as much as possible. So this isotoxic approach is a principle in stereo.
So you're saying that 5 millimeter is not a hard stop for you. You can go higher than that as long as your dose constraints are met.
Exactly. So for the small lesion, we may, the 1.5 centimeter it moves, we just treat in full breathing in ITB approach, because it's small.
Yes.
If the largest lesion, if it's far more, the 0.5 centimeter motion, it's central lesion close by heart and bronchial tree, and even small motion, we try to reverse gating, doing some motion management. And then when we do free breathing gating or breath hold, our first choice is around exhale, not the inhale. The two reasons exhale can be more efficient, so better Jury cycle, but most of the patient breathing patterns is a longer and exhale when they breathe out. And the inhale is a sharp peak, so there's not much time to beam on.
Yes,
And
I'm sorry if you misunderstood. I did say exhale. We do exhale.
Yeah. So that's a really important tip. The more important reason is it's hitting the same spot when you breathe out, right? So it's a consistency wise, exhale is more robust than inhale.
Yes.
But having said that, we do have certain cases we do the IBH like breast for central lung to create more space between the lesion and the central structures such as bronchial tree and heart. So those are the only rare cases we do DIBH, but anything like exhale, free breathing or exhale breath hold.
That's good to know since we haven't done any really central lesions yet, but that's good to know. Also, it's interesting you mentioned that you do. So yes, that was one of the questions I had for our consultant that, because the lesion is so small, we may want to go beyond the 5 millimeter motion because it's a really very moving in mostly one direction. But that would be helpful. We can reiterate that to our physician to use, as long as we're achieving the constraints, it'll be more efficient treatment.
Yeah,
I agree with that.
So other tip is a lot of lung cases like single fraction you showed is a good example. It's a budding attached to chest wall, and it's very hard to meet the chest wall constraint. For us, it's a 26 isodose line getting across the chest wall. That's what we check. And if it is too attached, too close, then we tend to compromise PTV coverage towards the chest wall side. And because PTV is not the lesion, it's including the rib or chest wall. So we are confident that if you do IGRT very accurately, and then we compromise there, and then to respect the chest wall was constrained.
Yeah, we do only look at the 30 cc constraints, not the max dose point, but for as of now, we've been making sure there's no hot spot, but the chest wall can get up to the prescription dose.
Yep.
But that's good to know.
And my last word is about single. Do we have time? Or it's already up?
Yeah, please go ahead.
Yeah. So I think this from physics point of view, we have a lot of questions about the single iso multi-target technique for stereo in the brain mets. We from us, I think the physics principle is larger off-axis distance is more susceptible to the given geometric error. I think that's the one of the question. If the file nets distributed all over the brain, we use a single ISO or group by maybe two ISOs, group different areas. So we limit 10 centimeter as an off-axis the limit. So we grouped the inner zone, which is within 5 centimeter, and outer zone between 5 and 10 centimeter from the chosen isocenter. And then we have different margin recipe. So anything we inner zone, we put 1 millimeter PTV margin. And at the outer zone, between 5 to 10 centimeter, we put 1.5 millimeter margin. Because with the same isocenter, further away, and then we have a 0.5 millimeter shift or rotation, that will give greater error at the lesion further away from the ISO. So that PTV margin should be in function of off-axis distance. And at the same time, you cannot put the different margin 1.1, 1.2, 1.5, 1.9. It's not pragmatic. So we have a step function like that. And then anything over beyond 10 centimeter off-axis distance, we consider we just better off to make separate plan with another isocenter. So we group in
done
that
that
way.
in some cases. We made a separate plan,
Mhm.
even for like three mets. Also, I don't know if we mentioned, we do have the 6-DOF couch. So we are able to give the rotations and such. But since you mentioned, I know there are devices now that are specific to these multi-isocentric lesions, where I have a colleague in the US, they actually got that device, and then they figured out that the off-axis lesions, they could actually see how much the those lines were shifting, and they had to increase. They use 1 millimeter margin from 1 millimeter to 2 millimeter based on that. So they were actually able to look at that. Do you have any of those? There are some companies who have actually came up with those devices with embedded.
Yes, we have our in-house simulation.
Okay.
But in Eclipse, because you demonstrated the variant solution, Eclipse has those uncertainty tool. We can simulate all 3 translation axes.
Right.
You punch in 2 millimeter off, and then you can calculate those and see how much coverage loss is there.
Okay.
So it's quite useful, but it cannot simulate known degree the rotation, but it can only simulate the translation offset. So we often use that to look at, and there are a number of papers. We also have one. So it shows that the longer off-axis distance, also smaller lesion, has a greater dose the coverage loss from the given the off-axis the correction.
Do you go by lesion diameters? If it's a very small lesion, and just to rule out the uncertainty, do you tend to give larger margins for a very small lesion, or nothing like that?
Yes, that's right. For the exact reason, the smaller lesion is more susceptible to lose the coverage, the off-axis distance. So we have the hard rule 0.5 cc, which is anything less than 1 centimeter diameter for the GTV, assume it's spherical. Then as a hard rule, we just put 2 millimeter margin on. Because it's too small.
Millimeter is a standard for us right now, so we start with 2 millimeter.
Yeah.
So, Dr. Wu, what's your protocol like for multi-mets if we are treating 5 or 6 regarding this chamber measurements. Are you measuring for each lesions, or have you made any institutional protocols? How many lesions are you measuring for this point dose?
In terms of measurements.
Yeah.
So yeah, when we enroll, it's a standard practice. In principle, any new types of techniques, we roll out first 20 cases, we measure everything. So if it's like 15 met in single ISO, we have to measure all. But
I see some physicists, our physicists not being happy.
yeah, so but as after we meet that requirement, let's say X number of patients, the X typically is 20 for us. And then we reduce the number of measurements. We just pick the most modulated cases and then smallest lesion. So we selectively choose only 2 or so. Yeah. And then if it's DCAT, like dynamic component arc, there's no modulation, which is elements option. And then we really don't need to measure, it's just open field with the arc. But if there's modulation, yes, we really need to measure at least first X number of cases to confirm how our system behaves in terms of the modeling accuracy.
Okay. Thank you. So thank you, Dr. Yu, for your time. And just today, the next session that's the practical session on the machine, and certainly that cannot be transmitted live. So we'll just take our guest to the downstairs to the linear accelerators vaults, and we'll present there. So thank you very much for your time, and we hope to see you probably live in Pakistan in coming years. And that was a wonderful experience. Thank you. Thank you, everyone.
Thank you.
Thank you.
Yeah, thanks for having me here. Thanks, guys.